The contents of this presentation are those of the authors and do not necessarily represent the official views of, nor an endorsement by, the Centers for Disease Control and Prevention, the U.S. Department of Health and Human Services, or the U.S. government. Hello, public health and other professionals. Today, the focus of this training video is the Foundations of Lead Exposure, Segment 3, Introductory Overview of a Lead Prevention and Mitigation Program in a Health Department. At the top right, there are pictures featuring a father with a young daughter in his lap, a picture of a mother and child at the doctor's office, and classroom with diverse students. In the bottom right is the Centers for Disease Control and Prevention logo, which also shows that CDC is a part of the Department of Health and Human Services. The purpose of this segment is to introduce trainees to the 4 strategic priorities for developing a lead prevention program and defined concepts explored further in Module 2. This segment should assist trainees in identifying features of a well-run program and the 4 major components of state and local lead prevention mitigation programs. The Secretary of Health and Human Services may make grants to states in consultation with state health authorities, to political subdivisions of states, and to other public entities to assist them in meeting the cost of establishing and maintaining preventative health service programs. The Lead Contamination Control Act of 1988 authorized the Centers for Disease Control and Prevention to initiate program efforts to eliminate childhood lead poisoning in the United States through the creation of the CDC Childhood Lead Poisoning Prevention Program. Such congressional authorizations guide how CDC engages public health stakeholders, including state and local governments, in fulfilling CDC's mission to accomplish a public purpose authorized by federal law. CDC's Childhood Lead Poisoning Prevention Program, in partnership with federal, state, and local health agencies, has a vision to eliminate childhood lead poisoning as a public health problem. They are also committed to the Healthy People 2030 goals of reducing blood lead levels in children and eliminating differences in average risk based on race and socioeconomic status as public health concerns. We will talk in depth about the 4 strategic areas of a childhood lead poisoning program. The 4 core strategic priorities for developing a lead prevention program, as per the most recent Notice of Funding Opportunity, CDC RFA-EH21-2102, entitled Childhood Lead Poisoning Prevention and Surveillance of Blood Lead Levels in Children. This 5-year cooperative agreement supports approaches for coordinating screening and testing plans, implementing effective blood lead surveillance systems, and developing policies and strategic partnerships and interventions to ensure a comprehensive system exists for the identification, referral, and follow-up with children exposed to lead. Primary prevention of childhood lead poisoning through targeted population-based policy interventions, with the focus on community-based approaches for lead hazard eliminations, is also part of the core program strategies. This Notice of Funding Opportunity also supports the Federal Lead Action Plan to reduce childhood lead exposures and associated health impacts developed by the Lead Subcommittee of a President's Task Force on Environmental Health Risks and Safety Risks to Children. In this segment, we will discuss the importance of blood lead testing and reporting. Why do we test children for lead? We test because lead can permanently impair cognitive abilities and cause other health effects, yet a child may not show evidence of such symptoms. The identification of a child with high blood lead levels prompts a public health response. This response can include a nursing visit, an investigation to identify the source of lead from the environment or brought home from occupational or recreational activities, and chelation therapy if blood lead levels are greater than 45 micrograms per deciliter, or if chelation is recommended by the doctor. Early intervention is important for reducing additional exposure. Children and their families can be linked to other services that can help mitigate the effects of lead. And finally, blood lead surveillance data can identify high-risk groups and other areas for health departments and providers to focus on. In 2012, CDC introduced the concept of a blood lead reference value. This is a population-based reference value to identify children with blood lead levels greater than 97.5% of the children aged 1 to 5 years. In 2012, CDC replaced the level of concern of 10 micrograms per deciliter of blood and introduced the blood lead reference value of 5 micrograms per deciliter based on the most recent National Health and Nutrition Examination Survey, known as NHANES. A shift in the reference value would allow practitioners to identify more children exposed to lead. In 2021, the Lead Exposure Prevention Advisory Committee, recommended lowering the blood lead reference value from 5 to 3.5 micrograms per deciliter. This recommendation was based on a report produced by the committee's Blood Lead Reference Value Workgroup that looked at NHANES data from 2015 through 2018. CDC concurred and lowered the blood lead reference value to 3.5 micrograms per deciliter in October of 2021. There is no safe blood lead level in children, and even low levels of lead in blood have been shown to affect learning, ability to even pay attention, and academic achievement. Calculated from the two most recent cycles of data from NHANES, CDC's new recommended blood lead reference value is 3.5 micrograms per deciliter. The blood lead reference value is not a clinical reference level defining an acceptable range of blood lead levels in children, nor is it a health-based toxicity threshold. Rather, it's a policy tool that identifies children who have higher levels of lead in their blood compared to most children in order to prioritize prevention efforts and evaluate their effectiveness. This information could be used to target high-risk populations in geographic areas with the greatest need for intervention. A line graph showing the blood lead level of concern for reference value over the years from 1960 to the present. What are key steps for blood lead testing and reporting? It's important to develop and sustain a statewide lead advisory committee. Having a statewide lead advisory committee creates collaboration and coordination between the appropriate stakeholders. It's also important to develop or update an appropriate statewide testing plan based on local data and implementation of the statewide testing efforts. Develop criteria to identify high-risk geographical areas, and identify the number of children less than 6 years of age that live in the high-risk areas as well. It's also important to increase awareness of pediatric healthcare providers and clinical labs of state blood lead testing recommendations via distribution of the statewide testing plan. Finally, it is important to list the at-risk populations that have been identified using the most recent surveillance data. The presence of lead throughout the environment increases the potential for sample contamination that can lead to inaccurate blood lead test results. CDC provides training, technical assistance, and quality assurance programs to help labs in the U.S. and globally ensure their lead test results are accurate and interpretable. A gloved hand holding a test tube with blood from a blood lead test. In 2018, the CDC released a training video entitled Mission Unleaded: How to Test Children for Lead with Maximum Accuracy, to help healthcare providers and laboratorians reduce the risk of contamination when collecting blood samples for children for lead testing. Implementation of these best practices will help ensure that children are tested for lead exposures with maximum accuracy. This training video is available via YouTube. The CDC logo on a poster for the video Mission Unleaded: How to Test Children for Lead with Maximum Accuracy. A picture of two women in medical scrubs is shown. The video can be found at https://www.youtube.com/watch?V=G2P2Q E9G. In this segment, we will discuss surveillance as a strategic priority. Childhood blood lead surveillance systems at the state level integrate information from several sources, including state and local childhood lead poisoning prevention programs, public and private laboratories, and information from health, environmental, and housing agencies. It's important to note that a comprehensive surveillance system will integrate both adult and childhood exposure data. Funded partners maintain their own child-specific databases in order to identify duplicate test results or sequential test results on individual children. These databases contain data on children with higher blood lead levels, including information on medical treatment, environmental investigations, and potential sources of lead exposure. CDC processes and validates data submissions on an ongoing basis and works with the states to reconcile any submission errors in required data fields. CDC applies rigorous error checking and validation algorithms to the data submitted to ensure only one test per individual per year is counted. Therefore, information available from CDC will not match data reports from the individual states because states may use different case definitions for clinical and environmental management. Some key objectives of childhood lead poisoning surveillance programs within your state and local jurisdictions should identify children at risk for lead exposure, prioritize high-risk geographical areas to develop statewide testing recommendations, should also identify emerging sources of lead exposures and inform of their strategic plans to remove or reduce those sources. It's also important to evaluate the timeliness and efficacy of case management services available to children with lead poisoning and work with your environmental inspectors and home assessors to ensure safe living environments. What are some state factors that could impact blood lead data quality? There are 4 key areas I'd like to discuss. What are your testing laws within your jurisdiction? Are you doing universal or targeted testing? Which age groups are you focusing on? Specifically children in higher risk geographical areas? Are you adhering to the Medicaid requirements which state all children enrolled in Medicaid are required to receive blood lead testing at the ages of 12 and 24 months? In addition, any child between 12 and 72 months with no record of a previous blood lead test should receive one. What are your reporting laws? Are you also adhering to the electronic reporting requirements within your jurisdiction? Another key factor that can affect blood lead data quality is the reporting context. It's important to think about linkages to other databases, such as your immunization registry. What are your staff resources? Are you able to ensure assessors and/or nurses are able to go out to homes if needed for appropriate follow-up care? What available technology do you have in place? What case definitions have you considered? It's also important to think about your action levels in terms of case management, environmental assessment, and referrals. Referrals include possibly linkages to nutritional services and possibly healthcare and outreach as well. In this segment, we will talk about linkages of lead-exposed children to services as a strategic priority. It's important to identify children with higher blood lead levels requiring follow-up. You should consider: what are some common follow-up services for lead-exposed children? And think of the best circumstances to initiate that type of referral. Some follow-up services can include additional blood lead tests, a visual inspection of potential exposure sites, a home assessment, risk assessments, as well as a need for home repair and remediation services. Please also consider a social service outreach if needed. Community resources, nutritional services such as with the Women, Infants, and Children Supplemental Nutrition Program, or WIC, may be required. In addition, there may be a need for developmental tracking and special education services. It's important for you to really think through your current process to ensure tracking of referrals are made and received for lead-exposed children. Also, partner with programs and organizations that provide these services to mitigate the effects of high blood lead levels and connect those children with the appropriate services to recommend medical, environmental, and social needs. The Women, Infants, and Children program is an important example of linkages to services. The Special Supplemental Nutrition Program is a federal assistance program of the Food and Nutrition Services of the United States Department of Agriculture for healthcare and nutrition of low-income pregnant women, breastfeeding women, and children under the age of 5. Their mission is to be a partner with other services that are key to childhood and family well-being. They also assist in the development of an appropriate nutrition care plan for those children identified as having a blood lead problem, including the provision of nutrition education and counseling by establishing a referral system for lead testing with identified programs. They also inquire during the WIC nutrition screening if a client has taken a blood lead test and make the necessary referral to obtain one when appropriate. It's also important during the visit that information is provided about lead poisoning prevention to their clients as well. In this segment, we will discuss targeted population-based interventions as a strategic priority. How can jurisdictions decrease lead hazards in housing occupied by vulnerable populations, such as children under the age of 6? Are you able to use data to identify your at-risk populations? It's important to prevent lead exposure through education and outreach strategies, targeting at-risk populations and development of local policies to reduce environmental lead hazards. Have you been able to develop strategic partnerships and policies to implement targeted, population-based interventions aimed at primary prevention of lead exposure with a focus on community-based approaches for lead hazard elimination? Have you been able to provide education and outreach to high-risk geographical areas and populations based on regional needs and those requirements? What are your partners' level of engagement? Have you been able to brainstorm with your partners, with those strategic organizations and institutions, when you're planning and implementation of evaluating your interventions? Think about what challenges and opportunities are associated with leveraging those partnerships to target the intervention. We'd like to discuss the Massachusetts Lead Law as a targeted intervention example. The Massachusetts Lead Law, 105 CMR 460, establishes a statewide program for the prevention and control of lead poisoning. This law requires the removal or covering of the lead paint hazards in homes built before 1978, where any children under the age of 6 reside. Lead paint hazards include loose lead paint on windows and friction surfaces, and other surfaces accessible to children. Owners are indeed responsible with complying with this law. The law allows up to 24 months to remove lead hazards and receive a letter of full compliance. A picture of a statue of Paul Revere riding a horse in Massachusetts. So now you may be wondering, what constitutes a comprehensive lead program? I'd like to share some key tips to consider for your comprehensive lead program. It's important to establish a functioning and sustainable statewide advisory committee. Your statewide advisory committee can help with key recommendations for blood lead testing based on your local data. They can also help to implement a statewide screening and testing plan based on your current data that provides clear blood lead testing guidance to pediatric healthcare providers. It's also important to maintain a blood lead testing reporting policy to ensure that clinical labs and healthcare providers understand and comply with your reporting requirements. Now I'd like to share an example of some of these tips mentioned, the Washington State Lead Poisoning Prevention Program. Their state health officer convened an expert panel back in 2012 to develop risk-based childhood lead screening recommendations for use by clinicians in the state. The Washington State Lead Poisoning Prevention Program partnered with the Refugee Health Program to screen all refugee children between 6 months and 16 years of age as part of the Refugee Resettlement Program. Over a 3-year period, from 2013 to 2016, they screened close to 3,300 children, in which 14% of the refugee children screened had higher blood lead levels and 3% with blood lead levels greater than 10 micrograms per deciliter. These children were then able to be linked to the appropriate follow-up services. A picture from Washington State showing a body of water with trees and mountains in the background. Some other important tips to consider for a comprehensive lead program. It's important to provide evidence of a sustainable and integrated childhood blood lead surveillance system, one that's able to generate population-level screening and test rates. It's also important to have follow-up data on environmental source investigation in which you can link referrals to recommended services for those children who have higher blood lead levels. It's important to collect essential information in terms of geographical locations, in terms of the zip code, or other census tract level information. Collaborate with relevant agencies such as Medicaid, your immunization program, even your refugee program within your respective jurisdiction to generate appropriate denominator and risk factor data. An example of a comprehensive lead program is the Arizona Childhood Lead Poisoning Prevention Program, where they worked with internal teams to identify opportunities for improvement in data quality and data management processes during the transition of their lead poisoning surveillance system into Arizona's communicable disease surveillance system. Their Childhood Lead Poisoning Prevention Program, or CLIP, evaluated pre- and post-transition data management processes to determine whether improved efficiency was achieved. To evaluate these key strategies, indicators regarding data flow were used. How they captured the data and surveillance capacity was considered as well. The key strategies were successful in improving the data quality, data efficiency, and expanded surveillance capacity, which helped to establish a foundation to better understand lead poisoning challenges affecting Arizonian children. An image from Arizona containing nature, valley, canyon, and mountain on the left. Additional tips to consider for your comprehensive lead program are to provide evidence of alerts available in your surveillance system to flag and track children with higher blood lead levels who will require follow-up and linkages to services. It's important to implement data sharing, data matching, and/or a memorandum of understanding with your key partners. It's also important to develop and conduct outreach, as well as educate your lead workforce, your partners, and other key stakeholders. An example would be the Rhode Island Childhood Lead Poisoning Prevention Program, where in 2011, 4 cities in Rhode Island reported having 3 times the number of children with blood lead levels greater than 10 micrograms per deciliter, with other Rhode Island cities and towns. It was noted that an estimated 80% of Rhode Island homes were built prior to 1978 and likely contained lead-based paint hazards that can create lead dust hazards during renovations to these homes. Rhode Island implemented the U.S. EPA's 2010 lead-based paint renovation, repair, and painting rule that requires workers to be certified and trained in the use of lead-safe work practices and requires renovation, repair, and painting firms to be licensed by the Department of Health. Following the first full year of the program, 180 cases of the renovation, repair, and painting violations were prosecuted by the Providence City Solicitor's Office for failure to obtain lead-safe certificates for these rental units, and there were roughly close to 130 fewer cases of children with higher blood lead levels in Providence. An image from Rhode Island showing a lighthouse on a rocky shore on the left. This presentation was developed in collaboration with the American Academy of Pediatrics and Commander Monica Leonard, an officer in the U.S. Public Health Service and former acting chief of the Lead Poisoning Prevention and Environmental Health Tracking Branch, or LPPEHTB, of the National Center for Environmental Health at CDC. Currently, she serves as the Senior Environmental Discipline Chief for the Public Health Emergency Response Strike Team with the Office of the Secretary/Office of the Surgeon General. The contents of this presentation are those of the authors and do not necessarily represent the official views of, nor an endorsement by, the Centers for Disease Control and Prevention, the American Academy of Pediatrics, the U.S. Department of Health and Human Services, or the U.S. government. Thank you for viewing Module 1, Segment 3.